Yes, this is called the A train. If we see a train like this of high frequency, several seconds duration, this can mean that a nerve carries a high risk of damage to a nerve. So like the surgeon hit badly the nerve with an instrument, we must warn him immediately, sometimes ask the doctor to irrigate the field if
the time of the discharge is related with the risk of damage. More than 20 minutes summated in one surgery, you need to warn the surgeon the high risk of lesion. You can resume IOM in one word, stop and go. The surgeon must be prepared to really use IOM. It's a tool he requires to the surgery. He must use that tool. And the first, when I was starting to do IOM, the surgeons are not trained to use my service. So they ignore my warnings. And a few times, one patient or another wake up paraplegic because they refuse to acknowledge what I was warning them. But with the time, the surgeon is going more and more confident in what we are telling to them. Because they test us in the middle of surgery. Frequently they touch a nerve root and wow, this is the L5 left. So they are going more and more confident. I believe, if I can speak to you, not as a doctor, because medical technology is not really what is important for you. But 3 times ago, I had never heard about IOM. Now I'm doing more than 200 surgeries a year. I'm finishing my first 500 surgeries in 3 years. And in the first, I was doing 1 surgery in a month. But IOM is like the late Steve Jobs used to say. It's a market that the customer will not require. You need to create this market. You need to remember the surgeon that this exists. And in 2012, it doesn't. It's not allowed to not use this tool. Just for your knowledge, a surgery like scoliosis is a high-risk surgery. 1 to 5% of the patients, and those patients usually are little girls from 12 to 13 years. You wake up from the surgery, who is intended to correct their spines, paraplegic, forever.
Good.
Forever. And you can lower this risk in 70% doing neuromonitoring. In degenerative disease of cervical spine, something so common in our country today, because our country is getting older, you can lower the risk of paraplegia or tetraplegia in 48%. This year, in February, the American Academy of Neurology releases a guideline acknowledging that the evidence for IOM preventing tetraplegia and paraplegia is class 1 in evidence. So this is something we can't ignore anymore. And also our client, and who will be our client? A neurophysiologist, okay? It depends on your country. In our country, a technician is not allowed to do intraoperative monitoring because anyone but a doctor can do anything related to diagnosis in Brazil. In USA, it's the same thing. But there is a difference. They have a real technician trained. A guy who has a major in some kind of health-related physiotherapist, This guy will frequent a school for 2 years. You need to go to 300 surgeries before he gets an exam, an oral exam, and a written exam, and he will be able to really perform IOM supervised by a physiologist, a physician. So the technician is really somebody that will be a client. Yes, he will be a client. But it depends on your country. I don't know how many countries we have here. 17, yes. Something to be studied. Our benchmark in Brazil is Europe and USA because it's so well established here in Europe, the use of intraoperative monitoring. There's a service here in Germany, in Tübingen, if I forgot well, that in 12 surgeries a day, 8 of them are monitored. And I live in a small country, just 800,000 people. And today we have 20 surgeries a day monitored. And I'm traveling Brazil from Amazonas, that is in the north of Brazil, to Joinville, it's in the far south of Brazil, Rio, São Paulo, and living inside a plane, performing neuromonitoring all over Brazil today, because the necessity is overwhelming. Only you train a doctor in some city, and he starts to do. This is a train that will gain momentum and never stops anymore. I believe Neurosoft was very wise to pick up this train, because if the train don't start to move in your country, this is the time to put the train to move. It will be not use. Try to pick the train when it's already 300 kilometers an hour. And Neurosoft devices are recognized in Brazil for neurophysiologists much more experienced than I. It's a very good device because of the silent to ratio, the quality of silent noise to ratio is it's very good. And the operation room, it's an environment very electrically hostile for neurophysiological studies. And this is one of the most demanding things we need from a device like yours. And also the quality-price relationship is very good for your device. But I believe this is all I have to say, and if you want to ask anything.
And as Luis testified, you have to be patient if the market is not yet developed. 3 years ago, he was performing like 1 or 2 each month. But once it happens that the surgeon learns what he can profit from him, he never stops asking again.
Yes.
Maybe in 10 surgeries nothing happens. If once it happens that an alarm sound is fundamental to prevent damage, he will always be asking IOM, and his need will spread to his colleagues like infectiously. So even if you do not have demand, be patient, start working, study the market, because it will surely develop in the time.
The neurosurgeon will have the experience of how silent the nervous system is. But he is not silent, in fact. In a surgery, the nervous system is screaming all the time, but it's electrically screaming. And the only way to hear that screams is performing IOM. And once we turn on the loudspeaker, he never will go back anymore. He becomes, in fact, very addicted to IOM in neurosurgeons. This is my experience, and not just my experience, but all my colleagues. We have maybe 50 neurophysiologists in Brazil doing.
I believe 3 years ago it was only like 10, but now we're reaching this number.
50.
And every month we're selling 2 IOM devices, I believe, for specialized neurophysiologists. And it's been easier to find training. You can go to the procedures with the web.
It's hard to learn, but you need a guy who's already a neurophysiologist, because to learn from zero is very difficult. You can teach Finnish literature for a guy who doesn't know how to speak Finnish. You know, neurophysiology is a language. You need to know the basics. And you are doing a lot of different kinds of studies at the same time. You need to do multimodal neurophysiological studies in IOM. And you need to do a lot of studies.
So,